A 37-year-old man suddenly developed acute headache accompanied by nausea, acute headache, were vomiting and impaired consciousness. Vomiting and impaired consciousness. Objectively, the blood pressure is 190, 120. This is high. The face is hyperemic. Patient's consciousness level is clouded. His answers to questions are short and monosyllabic, like in yes, no, okay. Movement and sensory disturbances are absent. Look, movement and sensory disturbances are absent. So that should tell you that there is a problem inside the brain, isn't it? But look at the next phrase or the next question, sentence. Meningeal signs are positive. They didn't say meningitis is present. Too. They said meningeal signs are positive. Meningitis is just another example of a meningeal what? Or let me say a disease that can cause meningeal what? Symptoms. But not only meningitis can cause meningeal symptoms. And when we talk about meningeal signs or meningeal symptoms, we are referring to the Brudzinski, the Babinski, the neck stiffness, photophobia, phonophobia, the intoxication syndrome, that's the headache, the vomiting, the nausea. These are meningeal what? Signs. They say it is positive. That means it has a problem with the brain, no doubt. But again, how do we differentiate between problems that can cause meningeal symptoms? We look at the cerebrospinal fluid. We look at the cerebrospinal fluid, and depending on what is there, it helps us to diagnose the person of the exact disease that is causing the meningeal signs. And over here, they are saying that the cerebrospinal fluid contains what? Blood. And you know, CSF is devoid of blood. There's not supposed to be blood inside the CSF. So to have blood there, it means that hemorrhage is taking place inside the brain. Hemorrhage is taking place. And that's why over here, your likely or provisional diagnosis should be subarachnoid hemorrhage. Subarachnoid hemorrhage. Maybe the person hit his head on something or something. Nobody knows. But if we're talking about what? Subarachnoid hemorrhage. So the answer should be B. Subarachnoid hemorrhage. All right. A woman undergoing inpatient treatment for viral hepatitis B. Okay, so the liver is infected. B. Developed headache, nausea, recurrent vomiting, memory lapses, flapping tremor of her hands, and rapid pulse. Sweet smell from her mouth is detected. Sweet smell from her mouth is detected. So that definitely can be what? A poison. That's a poison, intoxication. You know, ammonia has that kind of sweet smell, isn't it? And we know that the liver is responsible for detoxification. So when the liver is kind of inflamed or having problems, what can happen is that the bad substances like the ammonia cannot be detoxified. And this can even have problem with the brain. And that's what having what? Memory lapses, tremors, because now they are affecting the brain. And the brain doesn't like these ammonia gases or this ammonia. It has to go out of the body. And usually what the liver does is that it helps it to undergo what we call the urea cycle so that it can be converted and taken out of the body. But here's the case, the liver, somebody is on treatment with hepatitis B. So we don't know why, even though the person is on treatment, so why could this be happening? It's only one thing. It could be that the liver is definitely what? Failing. So when there's a severe liver failure, that is when we can have this thing what being present. So maybe they have to revise their treatment for the hepatitis B. They have to revise the treatment. Okay. Now temperature is 37.6, heart rate is 89 per minute. What complication has developed? Exactly. What complication? We are talking about what? Acute liver failure. Acute liver failure. So over here, we are looking at what? At A, acute liver failure. All right. A 43-year-old man, coal-face worker with 15 years long record of work, complains of cough, thoracic pain, dyspnea. So this is, of course, definitely what? A pneumoconiosis disease that we're going to look at, isn't it? And under pneumoconiosis, we have a different type depending on the occupation. This person deals with coal, coal, coal. All right, coal worker, coal face worker. Now the cough is mild, usually dry, occurs mostly in the morning. Pain is localized in the interscapular region and aggravates during a deep intake of breath. Dyspnea occurs during physical exertion. That's difficult to breathe. Vesicular respiration in the lungs is weakened. Heart sounds are rhythmic. Heart rate is 86. Blood pressure 135/80. Abdomen is soft and painless. X-ray shows micronodular pulmonary fibrosis. So there is what? The tissues in the lungs are undergoing what? Fibrosis. In other words, they are scarring. They are what? Scarring due to the action of the cold, isn't it? And what is the provisional diagnosis if you are dealing with what? With cold? Definitely over here, your best bet will be what? A black lung disease. Black lung disease. Black lung disease, which is also called what? Carboconiosis. 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 More or less like carbon. So carboconiosis. Carboconiosis. So that is what we are looking at over here. So due to exposure to coal dust, exposure to coal dust, exposure to coal dust. Yeah. So basically, over here we are looking at what? At carboconiosis. Carboconiosis. Of course, it is also similar to silicosis. In silicosis, you are inheriting what? Or you are inhaling silica or silica dust. You are inhaling silica dust, isn't it? So over here, we are basically dealing with carboconiosis. So your answer should be what? Should be D. Should be D. Should be D. If it would be lead or a welder, maybe you could think of what? Siderosis, because lead could be present, isn't it? If it's mercury, then you could think of what? Metal pneumoconiosis. All right. So depending on the pathogenesis, you can know your diagnosis. Having examined a 52-year-old patient, the doctor diagnosed him with obesity. There is obesity. Body mass index is 34, weight circumference is 112, and arterial hypertension. Guys, I know I've given you guys classification for body mass index. I mean, classification for obesity. Type 1, type 2, type 3, type 1, type 2, type 3, I guess. Please, I've given you guys one of our videos. Try and give me the body mass index. I mean, the types of obesity. This is not part of the question, but just give me types of obesity. Do it on the Telegram page. All right. So this is an assignment for all of us. Let's come up with the body mass index and classify the type of obesity this person is having. So this is what obesity, but let me know the type in the Telegram page. All right, not now. At the end of the tutorial, you can check it out. 2-hour postprandial blood sugar is 10. So sugar level is 10.8. What biochemical analysis needs to be conducted to diagnose the patient with metabolic syndrome X? Metabolic syndrome X. When we say metabolic syndrome X, they are referring to insulin resistance. Insulin resistance. Insulin, or we might call it syndrome X, also known as what? Insulin resistance. And this is a multifactorial disease with multiple risk factors that arises from insulin resistance. Insulin resistance accompanying abnormal adipose deposition and function. So when there is insulin resistance, don't forget the last time we were talking about the relationship between insulin and fats, isn't it? We talk about it, I remember. Insulin and fat. And we are saying that the insulin, in a way, has a role to play in fat because it prevents hydrolysis of fat, or it prevents the breakdown of fat. So when insulin is resisted, or when there's insulin resistance, that means insulin are not being absorbed by the tissues. by the tissues, isn't it? So inside the blood, you might see a whole lot of what? How do you call it? A whole lot of what? Uh, Fat inside the blood or cholesterol inside the blood, isn't it? So that's what we're looking at in this question. And again, this person is obese. Obesity. Obesity. So what are you going to do? Or what are you going to conduct to be able to help you with the metabolic syndrome X? And over here, you are going to do what? A lipid profile. Lipid profile. Because lipid profile tells us the number of triglycerides that are present, number of cholesterol, low density, high density lipoproteins, and all of these things. And you know, people who are fat, definitely their cholesterol level will be high. Their triglyceride level will be high. Eventually, they will be high. Okay, so that is what we are looking for in this question. So over here, your answer should be what? Should be E. Your answer should be E. Should be E. All right. After overexposure to cold, another question like this. This would they like these kind of questions. Another exposure to what? Overexposure to cold. I think I've done something like this already. A 45-year-old woman developed acute pain in her suprapubic and the lumbar what areas, suprapubic and lumbar areas. During urination, you know where your suprapubic area is. You can touch it just right. How do I even put it safe? Yeah, suprapubic bone. That's where it is. So that's where your bladder is, isn't it? Good. And under the lumbar area during urination, there are sharp pains at the end of urination. False urges to urinate. Urine is turbid with blood streaks. The doctor suspects urinary tract infection, of course. But what type of urinary tract infection will you be thinking about? Perhaps you might be thinking about cystitis, isn't it? Your guess is as good as mine. What result of laboratory analysis would be the most indicative of such infection? So even though they are not specific about the kind of infection, but generally, urinary tract infection, what are you going to be looking at? Definitely, you are going to look at what? White blood cells in the urine. And of course, they've told you that there are what? Blood streaks. Urine is turbid with blood streaks. So definitely, you can see the blood, isn't it? So we can talk about what? Gross hematuria. Gross hematuria. So over here, you're looking at what? Leukocyturia and gross hematuria. So over here, your answer should be what? Should be B. Leukocyturia and gross hematuria. Why? Because you are thinking of what? Urinary tract infection. So definitely you must see, you know, if you do the test, you will definitely see a lot of white blood cells inside the vision field. Let me put it that way. Okay. So your answer is what? Is B. Your answer is B. Your answer is B. And this blood streaks also help us to know that this could be what? A gross hematuria. Gross hematuria. We have a 62-year-old woman was brought into the admission room with complaints of severe burning retrosternal and asphyxia. So again, when you talk about retrosternal, you're talking about angina. You know, angina is because of what? Myocardial infarction, isn't it? Yes. And the person is having what? Asphyxia. That means hypoxia is developing in the person again. She has a 10-year long history of essential hypertension, guys. Essential hypertension is present. And you know, hypertension is a risk factor for heart pathology. Hypertension is a risk factor for a heart pathology. Now, objectively, her condition is moderately severe. She presents with a skin pallor, cyanosis, cyanotic lips, vesicular respiration over her lungs. The heart sound, second heart sound is accentuated over the aorta. Okay. Blood pressure. Look at the blood pressure, guys. Blood pressure is high. Good. Guys, see. ECG is showing what? Elevated ST segment. But I'm in a meeting now. But you can. Guys, a second. Yeah. Yes, sir. Welcome. Yeah, we had them. Okay, so where was I? Okay, we're having what ECG shows is showing ST elevation, ST elevation in these leads. So what are you looking at? So like I was saying earlier on, definitely we're looking at what myocardial what, infarction. Now with a blood pressure of 210 and 120, this is described as a hypertensive what crisis. So this is what hypertensive crisis complicated with acute MI, complicated with acute myocardial infarction. And that's over here. We are looking at what? At C. At C. Again, why? Because we're having what? Burning retrosternal, severe burning retrosternal pain and asphyxia. And already we are having what? MI. MI is present. But the MI is as a result of what? This increase in what? Blood pressure, which is 210. 210. And the person has a 10-year long history of this essential hypertension. Now it's no more essential hypertension. Now this is not essential hypertension. Essential hypertension is not more than 160. Okay. All right. So over here, the answer is C. So we have a 35-year-old patient who developed epileptic attack with tonic-clonic spasm that lasted for 3 minutes. After the attack, the patient fell asleep, but in what am I saying? Maybe, but in 5 minutes, but in 5 minutes, the second attack occurred. The first step of emergency aid would be, so we're having what? Epileptic attack. So what will you do? This is an emergency case. And I've already established that every emergency case, you follow a specific what protocol. What are these protocol? A, B, C. Where A stands for what? Airway, B, breathing, C, circulation. So the first thing you need to ensure is that there is patency of airway. Patency of airway before you can move to any other thing, before you start giving anticonvulsant drugs like the diazepam and whatever. So your first thing to do is what? Is to ensure that there is patency of airway. That's why your answer is A. Your answer is A. A 27-year-old woman, a teacher in the elementary school, complains of frequent stool up to 3 times per day with a lumpy feces and large amount of mucus, abdominal pain that gradually abates after a defecation. Irritability is there. Her skin is pale, ecteric. Mucus 74, redemic can be characterized as satisfactory. Blood pressure is that. Abdomen is soft, moderately tender along the colon on palpation. But guys, look at this. Fiber optic colonoscopy detects no changes. Guys, ladies and gentlemen, I've said this countless number of times. There's a difference between irritable bowel syndrome and irritable bowel disease. In irritable bowel disease, we have changes on colonoscopy. But in irritable bowel syndrome, there is no changes. However, the signs and symptoms might look the same. An example of irritable bowel disease is the ulcerative colitis and the Crohn's disease, isn't it? We established that already. So over here, we are looking at irritable bowel syndrome. Why? Because there is no changes in the colon or in the intestine. There's no changes. There's no changes. Although it might look like ulcerative colitis, whatever, but this is not ulcerative colitis. This is irritable bowel syndrome. I've discussed this again and again. So please do well to get the videos and watch them and revise. A 72-year-old man complains of lower extremity edema, sensation of heaviness in the right subcostal area, dyspnea at rest. So there's what? Edema formation, sensation of heaviness. in the right subcostal area. There's dyspnea. Over 25 years, he has been suffering from COPD. So whatever that's going to happen here is as a result of what? The COPD. It's as a result of what? The COPD, isn't it? Now, there's autopnea. I've already, I love this question. I love this question because I'm seeing some things here. And I think yesterday, no, 2 days ago, when we were doing a question on heart failure, I think Uche, if I'm correct, Uche was making some point with the heart failure, talking about some right and then the left heart failure. And I think I threw more light on it. Now look at this question and you understand what your answer is, or you will know what your answer is. Look, there's autopnea. That means when the person is lying down, the person cannot breathe. So you have to put the person in a cardiac position or put pillow at the back, at the neck area, so the person can be a little bit tilted, like 30 degrees. Guys, look, there's jugular venous distension. When I spoke or when we discussed about the right heart failure and in the left heart failure, you realize that in the left heart failure, there's no conspicuous jugular vein distension. But in a right heart failure, you will see what? A jugular venous distension. I said it over here. Now look, there is diffuse cyanosis and acrocyanosis. And if there's heaviness, okay, this is not peculiar to this one, but let me just focus on the heart for now. There is diffuse cyanosis and acrocyanosis, and I've explained these terminologies. Bluish discoloration. Bluish discoloration. Now, when there's bluish discoloration, it's either the heart is not pumping very well, or inside the lungs, they are not getting, or the blood is not getting enough perfusion, or exchange of gases is not really taking place inside the lungs. And what can lead to that is when there's edema inside the lungs. When there's too much fluid inside the lungs, that cannot happen. That cannot happen. Now look, there's a barrel chest is observed. I discussed the different types of chest. We talk about the funnel shape, the barrel chest. Now in the barrel chest, it means that the heart is inflated. Or let me say the lungs is inflated. So it makes the chest barrel. It's inflated. That means gases are not going out. Fluid or gas are not going out. But they can come in, but they can't go out. And again, why? Because the person having what? Chronic obstructive pulmonary disease. Obstructive, that means it's preventing things from going out. Air from going out. So the heart will become what? Hyperresonant. Too much of fluid will be there. But they're not undergoing correct perfusion. Now look at it again. On percussion, there's a tympanic bandbox resonance that tells you that there's too much air inside. Sharply weakened vesicular respiration on both sides. Guys, look, moist crepitant crackles is present. Again, it tells you that there's a presence of fluid inside. I was telling someone, I said fluid can be liquid or it can be air. So when I say fluid, don't confuse yourself. Heart sounds are weakened. The second heart sound is accentuated over the pulmonary artery. Liver is +3. What complicated the clinical course of COPD? Again, I was saying everything that's going to happen here will be because of what? The COPD. So what are some of the complications that can arise from COPD? And to be specific to this question, definitely we are looking at what we call cor pulmonale. Cor pulmonale. C-O-R. Cor pulmonale. You can Google it for yourself. Cor pulmonale. 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 Okay. What does it do? Or what is it about? This basically concerns itself with right heart failure, which we are having in this case. Why? Because there's too much fluid inside the lungs. The lungs is not going through the right perfusion. So the blood is supposed to go into the lungs are not going. Substances are supposed to go into the lungs through the pulmonary artery are not going. So you see, it has been accentuated over the pulmonary artery. Heart sound. That means there's too much pressure over the pulmonary artery area. Too much pressure is there. So the right heart is not sending blood to the tissue. And that is why there is regurgitation in the sense that, or there's stasis in the sense that blood is not moving from the inferior and then the superior vena cava into the right heart, into the right ventricle, into the pulmonary artery. Blood is not flowing. As a matter of fact, everything is coming backwards. Everything is the opposite. It's coming backwards. So as a result, everything will be there. And that's what there's what? Extremity, lower extremity, what? Edema. I explained this the last time we did it. 2 days ago, I talked about this when Uche was wanted a clarification. I talked about it. So yes, this is what cor pulmonale, which also means right heart failure, or is as a result of right heart failure. So over here, your best answer is what? Chronic pulmonary heart, which is technically the same as cor pulmonale. Okay, but the right word for them to have used could be either cor pulmonale or acute right ventricular failure. Acute right ventricular failure. So over here, your best answer should be the chronic pulmonary heart. So pulmonary, is from the right side. So we assume that that's what they're talking about. So this is what? Cor pulmonale. Cor pulmonale. Cor pulmonale. So your answer is what? E. Cor or chronic pulmonary heart. I believe by now, you guys should be experts in the heart. I mean, when it comes to heart failure. We have a 72-year-old man with pneumonia. Complaints of marked dyspnea, chest pain, and a severe cough with expectoration. That is, sputum is coming out. Temperature is 39.5 to 40. Is it to 40? Yeah, to 40. No urination, guys. Oliguria has set in. So if there's no urination, that means the substance that will be inside the blood will be too high. I mean, BU creatinine might be high, isn't it? Which is not good for the patient. And again, this is due to what? Pneumonia. Have you guys heard of KERP 65 before? It's a mnemonic. KERP 55. KERP 65. Good. This is to, don't worry, I'll come back to the question. KERP 65 has to do with how do you call it? How to assess the severity of pneumonia. Whether you have to treat the person outpatiently or inpatient treatment. KERP 65. C is creatinine. U is urea. R is what? Respiration. Yes, respiration rate, if I'm correct. KERP. What is B again? I've forgotten B. If you can remember, please let me know. KERP 65. There is B, and 65 is more than 65 years old. Okay. So when all these things are high, or they are 1 and 2, you might be thinking of what? Intensive care, isn't it? But over here already, you can know that creatinine level will be high, UL level will be high. Why? Because there's no urination. No urination. So it can't take away waste product. Okay. It can't take away waste product. Please, someone should search the B for me, the KERP 65, the full meaning. All right. So let's continue. At the end of the day, at the end of the lecture, I'll ask you guys for it. Now, objectively, the patient is conscious. Guys, look, respiratory rate is 36. I think it's not supposed to be more than 30 if you're having pneumonia. Now, over the right lower pulmonary lobe percussion, sound is dull. On auscultation, bronchial respiration is there, and the numerous moist crackles. Again, it tells you that there's fluid inside the lungs. Guys, look at the blood pressure. It's low, extremely low. Extremely low. Heart rate is 120. Heart sounds are muffled. Tachycardia. What tactics should the doctor choose? Guys, according to KERP 65, like I was saying, talking about, this would definitely require what? An intensive care. So that would be your mode of management. So the answer is what? E. Hospitalization into the intensive care unit. So your answer is E.